Good morning, everyone, and welcome to this insightful webinar on Guillain-Barré Syndrome, a rare but serious autoimmune disorder that causes muscle weakness and, in severe cases, paralysis. While it is often linked to infections, the exact trigger remains uncertain. Recently, new cases have raised concerns, particularly in the possibility of environmental and infectious factors playing a role. The ongoing outbreak in India has brought this condition into focus, highlighting the need for better surveillance, early detection, and effective public response. I, Rashmi Mabyankor, Principal Correspondent, along with Vikas Dandekar, Editor at ET Pharma, will be co-moderating this webinar today. We are also privileged to have a panel of distinguished experts who will help us understand the science behind GBS, its management, and ways to improve outbreak preparedness. Before we begin, I would like to inform the attendees that this webinar will include a panel discussion followed by a question and answer round by audience. Please use the chat box to submit your questions and we will address them during the session. Now, I would like to introduce our esteemed speakers. Dr. Shekhar Mande, former Director General, CSIR and Secretary, DSIR, Government of India. He is currently a distinguished professor at Savitri Pune University and a J.C. Bose Fellow at the National Center for Cell Science, Pune. Dr. Raman Gangakhetkar, Distinguished Professor, Faculty of Medical and Health Sciences, Symbiosis International University, Pune. Dr. Mukesh Kumar, Director and Head, Parkinson's Disease Unit, Neurology at Max Super Specialty Hospital, Saket, and Leena Megnani, lawyer consultant specializing in public health, pharmaceuticals, and access. So, a very warm welcome to all the experts, and thank you so much for joining in. My first question is for Dr. Ganga Khetkar. You have been closely involved in managing the past outbreaks in India. How do you assess the current outbreak management efforts? And do you think the containment measures on the ground are effective? And what do you think are the gaps in these implementations?
Thank you. No, there are certain things which we must understand. Perhaps India is facing, for the first time, clusters of infection which have hitherto not been reported. What is generally expected in a population, whether India or anywhere, is between 1 to 3 per 100,000 populations will develop Guillain-Barré syndrome, that is GBS. Right? Now, today, what we are seeing is a cluster. So, cluster would essentially mean the source of infection is perhaps common among them, which is leading to development of GBS. But are these numbers unusual? I don't think they are unusual. It is just that we are able to detect GBS now, and people are reporting numbers, especially from Maharashtra state. You find that even today, let's say from Bihar, the cases may not have been reported. But that doesn't mean GBS is not occurring in Bihar. It is just that the recognition is getting little better in states like Maharashtra. Now, the second question you said, that do you think the containment measures, you used the word containment, whether they are good. The reality of life is we do not know as much as to which infection is going to cause the GBS as such and in which individual.
Hmm.
To look at it, 30% of the cases, they tend to come from Campylobacter jejuni, which is a bacteria.
Hmm.
We'll also find that there are different viruses which are also associated with development of this particular infection
Hmm.
about 2 weeks after getting that infection, which includes, you know, the diseases like chikungunya, dengue. You also find even influenza vaccine. No, even
Hmm.
vaccination is associated with development of these infections. Now,
Hmm.
if this is the case, are we doing the right kind of containment? Perhaps we do not know which would be actually considered as a causative organism, which
Hmm.
results into more number of cases. The reason is cluster is occurring in the community, but these clusters are not reflected within the family also.
Hmm.
Because if water was the source, uh,
Hmm.
perhaps you should be able to see within the family. If there
Yeah.
was some genetic kind of a component which was associated with this, you should see more number of cases within the family. Even that is not occurring. So what it essentially means, this is an illness which we are trying to understand more. For containment measures, there are different things which are being tried. Something like water, which is a potable water, no? Not having this particular infection. Trying to see whether people can be advised about eating properly, which is also something which is a very vague thing.
Hmm.
So we are doing our best. The best is providing treatment to people as of now, at least in those states where this is happening, where it is getting reported, people are receiving better care at this point in time. Perhaps that treatment gap could be diagnostic gap and treatment gap could be high elsewhere.
So, Dr. Mande, if you would like to add something to this question.
Yeah, I mean, Dr. Ganga Khetkar has beautifully explained what are the potential causes.
Hmm.
What we should realize that GBS uh, might be an outcome of a prior infection. GBS itself is autoimmune disorder,
Yeah.
and in an autoimmune disorder, our body makes antibodies against our own cells. And there are many different kinds of autoimmune disorders which are known, and in the many of them, our own antibodies start attacking our own cells. In this particular case, in GBS, they essentially attack the nerves, and they kind of degenerate the myelin sheath of the nerve cells. That's what happens. But why does the autoimmune disorder arise itself is still being worked out. Many people have tried to find correlation to a prior infection, like Dr. Ganga Khetkar mentioned, by either Campylobacter jejuni, or by some of the viral diseases. And
Hmm.
it might so happen that the antibodies that were generated against those bacteria uh, have similarity, or the antigens of those species, virus or the bacteria,
Hmm.
resembled some of the components of human cells themselves. And therefore,
Hmm.
the antibodies also attacked human cells apart from attacking the bacteria and virus after they were cleared. So, the containment measure per se is very correctly pointed out by Dr. Ganga Khetkar,
Hmm.
are standard that not to have such bacterial and viral infections in the first place. And if the autoimmune disorder manifests, then handle it as per the standard protocols, and that's what is being done, I believe.
Okay. So, like we are seeing, the outbreak also coincides with the Mahakumbh festival. And when there is an outbreak, do you think this is only going to exacerbate the situation more, and would it lead to more bacteria or more cases, and a potential link could be further investigated, since the source currently that is being said is contaminated water?
So on today's date, nobody has found any evidence of Mahakumbh correlated with the outbreak of GBS.
Hmm.
In mostly the clusters, as Dr. Gankaketkar pointed out, were near Pune and around, and no one has been able to correlate that with the Mahakumbh as of now, right? But having said that, the science of GBS itself also is not clear on today's date, whether it is really correlated with Campylobacter jejuni or not. And Dr. Gangaketkar said that within a family, different people seem to have developed the symptoms and others don't. And we don't understand that fully yet. And
Hmm.
therefore, any correlation to any other event that is happening, I think would be rather preposterous.
Hmm. Hmm. So, Mr. Vikas, if you would like to take any question. So you're on mute.
Yeah, sorry. Yeah, no, so very interesting perspectives coming there. I'd like to get Dr. Mukesh Kumar in the discussion now. Dr. Khedkar, actually, Ganga Khedkar mentioned about cases reported in clusters. As a doctor, have you seen a higher number of patients coming up with the preliminary symptoms of weaknesses in limbs, or the initial symptoms? Has it been the case that you have suddenly seen a spike in such cases?
Uh, Look, GB syndrome, what we see is 60% related with the respiratory infection. And it is more related with the usual standard is 2 weeks before the onset of the weakness. We always ask for any respiratory complaint, viral urea, URTI is there or not. And similarly, 1 to 2 weeks history of loose motion is there or not. Usually in GB syndrome, these are the self-limiting URTI or self-limiting dysentery. So as per the data published, it is 60% influenza-related symptoms and 15 to 20% Campylobacter jejuni. But it is all about the statistics. Now the statistics played a role. It is seen that it is 1 in 1 lakh population. So 1 lakh, if Campylobacter jejuni is affected in 1 lakh population, then out of that 1 lakh, 1% may develop GB syndrome. If you see the seasonal variation, it is across all seasons. GB syndrome we see almost every week. It is so common. It's not like that we are seeing in cluster. It comes in abruptly. It is sporadic. It is not epidemic. It's not endemic. It is sporadic, and it can come in any point, and starting from 5 years to 70 years of age. But definitely, if you public health relation, then 5 to 15 years, we talk it in different manner because we term it as acute flaccid paralysis, and we try to correlate polio and other things, try to exclude that part. But as a neurologist, because we are more catering towards adult neurologists, all flaccid weakness, starting from the hand and lower limbs, we see 60% influenza, 15% Campylobacter, and the rest everything 20 to 30% undetected. We don't know why it happened. In some cases, if you see 70, I can say 15 to 20% are self-limited. Means they peak up to 2 weeks, and after that they get plateau and they recover spontaneously over a period of 6 months. This is possible. We have seen without any medication, it is possible to see. But severity of disease is individualized. So where it gets peak at what level, whether it peaks at all the weakness 0/5 power, or it is respiratory paralysis requiring ventilator support, or at least 2 to 3/5 hour, ambulatory with crawling and everything, that is difficult to anticipate. First 4 days of progression trend of weakness decides the future thing. If patient is able to walk up to 10th day of the symptom, it means the severity is less. The peak will be the less. So usually the severity is obvious within up to 5 days. Whether ventilator requirement happens or not, it is visible within 5 days of the onset.
Right, right. So, so combining the first three views, I'll again go back to Dr. Ganga Khedkar. You mentioned that it's happening in clusters, or, probably just the detection levels have gone up, and it's within the normal range of 1 to 3 cases out of 100,000. In fact, sometime back there was a report also which said that in monsoons, in Bombay at least, a lot of cases do come up in GBS. So do we characterize it as something that is a phase which is normally occurring, or do you think, because when WHO steps in, talks about its field staff working closely with the Pune health authorities, it kind of sends a signal of panic. How do we characterize this issue right here?
I don't know how to characterize panic for sure, because panic can be rational and irrational as well. But most of the people who are coming to try and show are trying to gain visibility of this GBS and their efforts. The reality of life is, as Dr. Mukesh Kumar said, the seasonal variation is pretty small. No, it is almost not there. If you go to any medical college, the tertiary care centers, because there the diagnosis is perhaps thought of, no? you don't think of this diagnosis occurring at CSC or primary health center. The result is we don't know what's happening there. So there is selection bias, huge selection bias, and you report that. The moment you report that, it doesn't necessarily mean the clusters that are occurring can be explained so easily. No, because
Hmm.
these clusters occurrence is actually dependent on different infectious diseases which are predominant in that area during a given period of time where vulnerability has been associated with GBS. No.
Hmm.
Now, for example, if it was dengue, all of us would have had said, "Oh, it is because of dengue. It is predominantly because of chikungunya virus, or it is because every adult is taking influenza vaccine now to prevent it, so it is related with influenza." It's like the classical story that people used to say that when you don't know anything, there were people who used to attribute Indian childhood cirrhosis to anything which they were associating. So somebody could say, "Oh, this is because because of the trunk of the elephant, because it could touch." They focused on that area. Somebody would say it is because of the legs of the elephant. Somebody would say it is because of tail, because you are focusing on it. But the reality of life is this association should become, research is finally one of the things which I would always say. We must start intensive research, however rare this disease is. For India, the rare disease definition tends to say that if anybody, has, let's say, 1 to 2 cases out of 1 lakh population, it becomes ultra rare disease, not even rare disease. So we need to have a good registry, do good studies to find out what is actually happening. And one of the things which perhaps Dr. Mukesh Kumar can explain little more, there are 5 different clinical presentations that come. We have identified them now. I think as the research will progress, you will find the association of Campylobacter having association with one particular presentation will become more clearer. And there are people who are trying to look at diagnostics developed for finding it out. And that's something which is very critical, because those diagnostics will come which will tell you what could be the next prognostic thing, whether there could be respiratory muscles that will go or whatever.
Yes, absolutely. At this stage, let me bring in Lena. So far it appears to be a situation that can be brought under control. Not too many, situations that have actually seen like a lot of problems occurring. Uh, how do you think we should prepare from here? If we are fortunate enough, things will be curbed, as we had seen in the case of 2023. I think there was a similar outbreak in Peru. It came down. From your perspective, Lena, do you think, in terms of building the guardrails, there is a lot of scope to do work here?
You can also see GBS as indicative of certain things that we can do in public health. Okay. So I just wanted to say this, that there are two things. The government is already doing surveillance. They're going door to door. They are collecting samples of water and other samples. So, you can already see that public health institutions and authorities have hit the ground running. Now, what else can you do? I think if there's fear among people about GBS, about developing GBS. And I think the most important thing is to provide very accurate information, education, and counseling about it. And that helps in two ways. One, it curbs, irrational fears about developing GBS, and people do develop those. And number two is that it helps people who have early onset of symptoms get medical treatment. So I think that's really critically something that has to be, the media is covering it extensively, and the government has an opportunity to really hike up IEC on that. Number two is this, that for a very long time, people who worked in public health have highlighted two things. that you can do a lot in preventive public health through wash interventions. And wash is, clean water and hygiene, right? If you look at antibiotic resistance and the response to antibiotic resistance, we can cut mortality and the use of antibiotics if we concentrate on wash interventions at the community level. That's also help in preventing GBS outbreaks, such as what is happening in Pune. I think it's a perfect moment to talk about the fact that we need to really strengthen wash intervention in particularly poor and marginalized communities who have much less access to clean water than people who are much better off. There are other interventions that are linked to, contaminated food, which is not linked to GBS, but I just wanted to highlight, the antibiotic response would, for example, require you to vaccinate people in the food industry against typhoid. And that's a brilliant intervention that you could do. And people are calling up and asking questions, can I eat my egg? Can I eat my chicken? But what we're not concentrating on is the two major public health intervention. What can we do about contaminated water? What can we do about hygiene? And what can we do about, the food industry, organized and unorganized? And I think this is where I come from. And I think tension on public health is what we need within the discussion about GBS. So I think that's there. And lastly, I wanted to say that all treatment for GBS should be free for people. When it's a minor case of GBS where you just go to the emergency, you get your diagnosis, and you don't need a ventilator. But if people, even it's a very minor number of people who actually get on a ventilator, all treatment must be provided free of cost. And I think these are some of the things that the government can absolutely do within its public health response.
Yes, yeah, absolutely an important point. In fact, immunoglobulins are not cheap. I think it requires a lot of funding, and I think in government hospitals they have made it free. So that's a good part. I have a set of questions for the next round, but for now, back to you, Rashmi. Your set of
Okay.
questions.
So, my question is for Dr. Shekhar and Dr. Raman. How do you think the government, when especially a case where we just come to know of cases and it kind of escalates, how can the government and research organizations really play a role in strengthening the surveillance, where because it suddenly creates a lot of panic, and strengthening early detection to prevent such outbreaks? What are the improvements that we can really do, especially if we can take some lessons from the COVID-19?
So the COVID-19 lessons were very clear because COVID-19 itself was infectious virus that was spreading. And to contain the virus spread, there were multiple ways that could be done. For example, doing aero sampling servicing, sampling the air in the affected areas or something like that. But to predict outbreak a few days before, people also were starting doing wastewater surveillance. That was done in multiple cities. Similar strategies can be used here if it is we know for sure that either it's because of norovirus or it's because of Campylobacter jejuni. We could actually put in place surveillance of wastewater, for example, or contaminated food, as Lina also mentioned, something like that. I mean, especially fruits and all those things, and whether they contain any traces of this bacteria or virus. But as I said, on today's date, the exact preceding cause of which infection led to GBS, we're still struggling to find that out. So the standard measures of surveillance of any outbreak of any kind of bacteria or virus, they should be good in place. I think Dr. Ganga Khedkar might wish to.
Some things which I must specify. What is needed most? One has to create awareness among all hospitals that if you get a case of ascending paralysis, you must report to IDSP. Now, whoever had seen as a general practitioner that case, if the patient develops ascending paralysis, the person must inform IDSP, which is a strong mechanism that we have. It is the job of IDSP to go to their homes, find out why this has happened, and then perhaps you may even be able to detect clusters far earlier than it has happened right now. Because nobody reported from the physician's side. Now, what the first 6 cases which I know, which were detected in Pune hospital, when they reported, it was the awareness of those people. And that's why they reported, they went to the press and they said these are the cases which are occurring. Press, that's a wrong place to go. Because if you go to press, they start saying, creating all kinds of scare, that there are 6 cases, some mysterious agent. Those kind of things need not be done. You can go to IDSP. IDSP can verify. Once they do it, then it is job of public health department to try and look at it as to how it has to be contained. That's number one. Second thing, which is also important for all of us to understand, is now that you have created some kind of scare, whether it is doctors who are responsible speaking in press, making rare disease as if it may lead to another COVID pandemic like situation. You please use this opportunity, educate people that if anybody in your own family develops this kind of symptom, the paralysis that tends to ensue, please go to the hospital at the earliest and let that hospital decide whether it has to be reported to IDSP and do correct things. Third thing which is important is educating media. Knowing that you have very low case fatality rate, knowing that we do not understand so much about the etiology, what leads to development of GBS. That is why it is called as a syndrome. Otherwise, it could have been an extension of that infection itself as a complication that tends to arise. What is important is they have to start thinking about it, that we should not write, today there were 4 cases, yesterday there were 2 cases, now there are 8. When this kind of counting starts, for a layman, it's a scary situation. I think what a layman demands from the press is take the information from a good doctor or even from the government and try to publicize it rather than jumping to one's own or developing some kind of a scenario through writing that government's attention must be drawn. I think we have to make a distinction. We have to ensure each one of us as a stakeholder has to take responsible action, because perhaps they do not know this was occurring for ages and now I am reporting these clusters. These clusters occur every year. Nobody has any idea. And this is the first time cluster is being detected. If it is detected, all as a stakeholder have to start thinking, how do I use this information positively to ensure the scare is gone, the fears are lesser, and people can do everything in a right manner, given that the mortality rates are low, the treatment is available, and government is giving free of cost.
Reshma, you are muted.
Sorry. Yes. So I wanted to say that I would like to come back into how strong, according to you, can the surveillance be made? Because of late, we have been seeing a lot of outbreaks. Even the HMPV caused a lot of panic, and now GBS, because people are not knowing. We only get to know when there are cases. So how do you think the surveillance has actually ramped up, and what are the areas that should be targeted which are more prone to any kind of disease outbreaks? Can we have like some kind of idea on that?
You are asking me?
Yes, sir. You and Dr. Mandey.
I have very blunt opinion on that. Surveillance should detect a new organism that could be circulating or causing disease where we don't understand much. why it is occurring. Once it becomes a cluster, it doesn't remain only up to surveillance. The surveillance would then only detect new cases that may be occurring elsewhere from the site which is occurring, which has been reporting that before. But more than surveillance, no. If you look at HMPV, I honestly, if you HPMV, HMPV, I honestly, I have made all kinds of statement in media on that. The reason is I couldn't understand why it was blown to a level which was not required. Please remember, every time when we go to the community, whatever anticipation that we try to develop within the community, if it doesn't hold true, they are going to lose the trust that we would have on media as well as medical fraternity. And that's something which we should not avoid, to my mind. I think we have to be scientific, dispassionate, very critical about evidence, and just move ahead. What has to be taken to the community? If I don't know how to prevent, why should I be speaking? If I don't know how to treat, though the mortality rates are low, no, what would I go and tell the community? If I know that it is an ultra rare disease, I have to ask a question, do I report as much in my newspaper or whatever place we are about TB, about HIV, about malaria, and suddenly the entire country is looking at a new disease, no, which is an ultra rare disease. So let government do its own job.
Right. Thank you, Dr. Raman. Dr. Monday, if you would like to add something.
Yeah, so surveillance is typically done for the cause if it is known. I mean, the bacterial outbreak or a viral outbreak, or even for non-communicable diseases, if the cause is known that obesity leads to such and such kind of a disease, then we actually do that surveillance and then try to educate people to avoid those kind of situations. Right? So, okay, in this case, if we hypothesize that GBS is caused because of an outbreak of Campylobacter, then definitely we can go ahead and then do surveillance of Campylobacter outbreak in particular areas or localities and say that we need to be careful and we need to be treating water or whatever in that particular area. But if the cause itself is not that well known, the general surveillance is taking place anyway, and surveillance for other important matters such as AMR and all is also needs to be actually put in place. So surveillance we continuously keep doing. ICMR is fantastic in doing surveillance mechanisms, and they keep doing for the causes that are known. If the cause is not known, surveillance itself becomes rather doubtful. But I think Lina has at hand for a long time.
Yes. So I was coming to Miss Lina. Your inputs on the same question, and if you would like to share if there are any critical challenges that you think can be addressed for outbreak preparedness and in healthcare infrastructure strengthening.
So what's very obvious is that government is taking this seriously and putting its best surveillance teams on this. You can, today's BBC has reported that they're doing household surveillance to see in Pune. So, I mean, what more can you ask? But there's a point to be made about, if you look at the AMR program and if you look at the AMR response, one of the things that most experts will tell you is this, that we are good at tertiary level surveillance. We are much weaker, the community level surveillance, right? And this is not about GBS So if you're looking at infections and you're looking at different kind of health interventions, whether addressing the misuse of antibiotics for viral infections, and you look at different ways people use antibiotics. You should be collecting data at different levels at the community level, and it's biggest challenges when you have to go into communities, and it's a lot of resources. So I don't see the government rolling out a massive surveillance initiative for GBS, but I think what the government will do is become conscious that is linked to viral and bacterial infections. And perhaps when the private sector starts reporting cases along with the public sector, which is what is very, very clear, is that the private sector, for example, I heard a critical care doctor in Bombay speak on Faye D'Souza's program, and she made a very valid point that they already have a registry at the Bombay level for GBS. So, already you have sources of data, and those can be managed to see how big this problem is. And I think what is really, really interesting is that the government already has put its, preparedness infrastructure into play and, gone about doing surveillance in Pune. So I think this is where we are. Community surveillance is much more challenging than tertiary level surveillance, as we've seen in antibiotic resistance. And that's where the challenge lies. And you have to be very careful about where you use, public health resources. Just an example from HIV. At the early days of HIV, everyone was asking, demanding that everyone be mass screened for HIV, everyone be tested for HIV. And some of us who had worked on public health, and perhaps Dr. Ganga remembers, we said, step back and said, well, if you test the whole population, our entire resources will be gone in testing. So where are you going to focus your testing on, and whom are you going to give access to, and how you're going to improve those public health interventions? And this is a similar story. You've got contaminated water, you've got bacterial infections across the country, you've got viral infections due to a variety of reasons. And where are you going to focus your public health interventions for those? Wash interventions, viral infections, controlling viral infections. The outcome will be your GBS cases will fall to the normal numbers. As we've seen in other developed countries, it's mostly, the United States has 3,000 to 6,000 cases a year, which is about one case for every 100,000. So that's where we are, with surveillance. We can't spend everything on surveillance. We need actual interventions that reach people. So that's a balance that the government now has to put in place. And I am really hoping that WASH interventions will receive the necessary support that, the AMR program and, people who've been working on AMR have been asking for.
Thank you.
Just
Thank you, Ms.
to
Pune.
stress what I said, WASH interventions, we gave lot of importance in COVID. No? You look at even the use of COVID appropriate behavior, it had increased a lot. It's just Omicron which destroyed it. Because whatever you advise to people, if those the community feels after some time they are not required, ineffective, we don't withdraw our campaigns. And the result is they lose trust. Otherwise, why, we had to talk about WASH interventions, because WASH was actually, it had reduced diarrheal diseases dramatically, road traffic accidents dramatically. You look at respiratory infections, today we talk about immune deficit, which means there were so less respiratory infections. I think prudence or balance would be required at this juncture in health sector. If I was to put it very bluntly, I would say, even if we are to look at prioritization, we should currently focus on 2030 disease elimination targets, because we are perhaps behind in those targets, rather than moving into new fashionable or visible area, even for the government. Government would not like to see that they have not done anything in this particular issue, because it is blown up beyond the proportions that it requires. This is a domain which could be handled professionally, to my mind.
Okay. So, Mr. Vikas, if you would like to take it from here before we start from the Q&A from audience.
Right. No, very interesting. In fact, some of the keywords that I can take from Dr. Ganga Khedkar is having a scientific temper, being dispassionate, having a critical view about all the evidence, and of course, the last one he mentioned was about prudence and having a balance. And the message is about really stepping up the surveillance part. Let me get in Dr. Mukesh Kumar again in the discussion. One of the reports, again, this is also not to stoke fear or panic, it's to allay any such apprehensions. One of the mentions was in one of the reports was about a potential shortage of ventilators. Again, it brings back all the things that we had seen a couple of years ago. Uh, from your point of view, do you want to say something that probably will give the right scientific side of the story? How much of it probably do you think is actually going to that stage where the case becomes serious? Do we really want to move in that direction, that everything again becomes saturated, ICUs, ventilators coming into the picture? So any thoughts from your
Yeah.
side?
Let me say you, 99.5% cases of GB syndrome is completely curable. It is only 0.5, it's even less than that. Okay. The main concern is if you see, 85% cases are demyelination and 10% goes into favor of axonal. Concern for this type of case is duration of recovery. So it's usually if patient is severely paralyzed or respiratory involvement there, the duration of recovery is 3 months. Okay, so hospital stay is usually with if such patient which requires ventilator support, hospital stay goes up to 1 month to 2 months. Less than 1% of all GBS goes to ventilator and tracheostomy, and even portable ventilator going on for 2 months. So the crisis lies here. So when the problem happens in the concept called it is a general issues, ki hospital bed scarcity, ventilator bed scarcity. Actually, we see after COVID, ICU setup and ventilator setup is across all district in India, all district. Even even the sub district also had a good ICU critical care after COVID. So it is an excellent health network now across India. Regarding the treatment and diagnostic thing, it is available in each and every district, and everyone is treating it even at the level of general physician. It's not missing a neurologist part. Regarding surveillance part, acute flaccid paralysis detection and reporting is already in picture since long. But that is mainly for the up to 15 years of age, not beyond that. Seasonal variation is visible. We know everyone is a rainy season, there will be a GB syndrome. We will ramp up IVIG, procure it, and start it. So even IVIG is started on the flip of doubt. Just confirm it and give it. Ultra safe medication, no side effect. Okay. IVIG, what to do? It doesn't give the recovery. It halts the progression of disease. So once you halt it in the minimum level of that before respiratory involvement, then you can slow down you can ramp up the process of recovery, or you can expedite the process of recovery with a spontaneous physiotherapy. So again, in conclusion, 99.5% cases complete recovery. Crisis lies with the 0.5% cases where the ventilator requirement, portable ventilator, and the infection during this process in this 2 months of hospital stay. This is the one issue, but this is so uncommon, and every tertiary care hospital know how to handle it. So as of now, I will not say that there is shortage of ventilator. No, it is wrong question, wrong thing as of now.
Sure.
The concern is, yes, hospital stay means one bed gets occupied. Yes, how to train the family members to handle the tracheostomy and portable ventilator. Tracheostomy training and this nursing care, that's a lacking. So usually not seen in private or government hospital, very good in the private part. So this is definitely, it is less than 1.1% cases.
Very interesting. It's very big relief to hear that 99.5% cases will recover. So it's a very minuscule part which probably will require a higher level of treatment. Right. Dr. Gangakhetkar sir, you mentioned at the initial part about some of the states not really reporting, and we are seeing more reports because there is more diagnosis. So essentially, we require a much more robust machinery to also diagnose across states. So in your earlier capacity in ICMR, and then you also mentioned about need for diagnostic kits. Uh, and we've seen a huge crisis coming all over the country and the entire world, actually. So do you think there is a change now which is happening in that direction? Do we see more people coming up on diagnostic side in terms of early detection so that things are brought under control?
No, I'll come first to, because I think I'm misunderstood, to the diagnostics. No,
Okay.
when I said diagnostics, is diagnosis not possible? Possible. It's more of a diagnosis on exclusion, and they have to do CSF studies, which are possible anywhere, cerebrospinal fluid based studies. So,
Oh, yeah.
and you have radiologic tools which are also available, reasonably good access that is there everywhere. Now, when I mean diagnosis, I said this is a syndrome. The reason when we say syndrome, it means this is, we cannot attribute it to one etiologic agent, right? Now, are we likely to become clearer? Now there are certain genes which, genetic material, let's put it in simple words, genetic material, if we detect, they are associating strongly with what is likely to happen in this particular case. Those kinds of tests are yet to become available. They are still not validated, but the movement is on globally. Not only in India, it's elsewhere also. This was about the first question. The first one was what? I forgot. I'm sorry. What was the first one? No, I'm not able to hear.
Yeah, yeah. No, this was about having a much more robust machinery for early detection.
Yeah. See, that is a problem that is existent everywhere. Unless you teach them, unless you train them, unless you create, what, inquisitive eyes, then you are unlikely to detect it. You will find that there will be deficiencies across.
Sorry for interruption. Just
Bolo
and
na sir.
there is some neurological aspect in this. Actually, detection, diagnostic means MRI spine to rule out myelitis, spinal cord involvement, nerve conduction study to look for the demyelination evidence, and the CSF to look for the immunocytoscore dissociation. And fourth is blood testing to rule out hypokalemia and hypocalcemia. These are the four things. And all in combination, then we exclusion diagnose the GB syndrome and then start IVIG. If you see all these things, this requires a higher level where the multi-specialty center is available. Means it is not possible at the level of sub-center or primary health center. Wherever the MD physician is or where the critical care setup is available, you can do everything except nerve conduction. Wherever the nerve conduction facility means you need a neurologist assistance. Okay, so nerve conduction is one thing where it is always in the neurological domain. Whether you have to neurosurgery or psychiatrist. Sometimes psychiatrists also play a role of doing the nerve conduction. So, but as of now, we say the neurologist, neurosurgeon, and psychiatrist, all three are available in each district. Not in government, but definitely in private. Government center, it is mostly in the capital or a group of some district. Then neurological facility is available. So here the concern is what you are saying is diagnosis is not diagnostic in one kit. It is a combination of things. It is a clinical presentation. It is a MRE exclusion. It is a CSF finding and blood testing. All flow, everything excluded, then GB syndrome, and then things more rolls out.
Much
So what
complicated.
essentially Dr. Mukesh Kumar is trying to say, that the diagnosis may not occur at primary health center.
Right.
It may not occur at sub-district level.
Yes.
But if I train them to send certain kinds of cases, refer them across, perhaps that diagnosis can very easily occur in places where access to these modalities is there.
Got
So
it.
we have to retrain our systems, but as I keep on asking a question, am I going to focus on rarest kind of diseases or diseases where we know everything and we are unable to control them?
Sure. Lena, from your point of view, having seen so much of global upheavals up close, even being associated with so many action groups, what do you think should be the global program? We are seeing pandemic treaty going nowhere. It just keeps on coming in discussions. My thing is that, what if there is a really a bigger outbreak? Are we going to be more prepared, or is it going to be the same kind of a situation that, it's more reaction to a problem than being prepared?
Well, the fact is the pandemic treaty has not been fully negotiated. And one of the reasons is that certain member states keep weakening provisions that are meant to bring about more equal distribution of the tools to address a pandemic, whether it's, you can look at diagnostics, or you look at vaccines, or you look at therapeutics. And I think this is where we are with the pandemic treaty. I think the withdrawal of the US as a member state of the WHO gives an opportunity to the WHO, in fact, to look at bringing consensus on some of the most contentious issues about sharing resources at a crucial time when you have a pandemic such as you did in COVID. And I think that's where we are. And at the national level, I can just simply say that, of course, the government's response indicates that they are now looking at these outbreaks, small or big, important or not, as an issue of health security. It's something that is really, health is now much more political than it was in 2019. So I think seeing a public health infrastructure respond to an outbreak in Pune is really heartening. Much better IEC, I would say, is something that we require. At the global level, I think people know the challenges of another outbreak or a pandemic, but are unable to come to consensus, which is really unfortunate. And that's not because of low and middle income countries. It's more because high income countries are unwilling to give up the control of the means of manufacturing and resources to manage a pandemic. So that's where we are.
Right. I'd also like to ask a question to Dr. Mandey about the innovation efforts centered around these kind of emergency situations. Sir, what are your thoughts on that? How prepared is the country's research establishment now as compared to what we had seen about 3-4 years ago?
You see, the COVID period was a very deep learning experience for all of us in promoting innovations on all fronts, and also on government's response to any future possible contingency situation such as COVID. So, for example, government has now set up One Health Institute. That's essential idea is to be prepared for future pandemics, and we don't know where the pandemic would come from. So continuously look out for anything that might actually be transmitted through zoonosis or whatever. But apart from that, promoting innovations, it's extraordinary thing that is happening at this moment is the number of startups, the number of people also getting into medical devices, the number of people getting into the health sector, younger people, and doing that is simply extraordinary. As what we witnessed today, if you look at the numbers in the last 4 or 5 years, that how this thing is going up. Even some of the bigger players who have come into the picture, for example, the Tatas and all those things, was not there about 4 or 5 years ago, in this particular sector. So we do see a huge push for overall innovation ecosystem, starting from grassroots innovation, starting from younger generation startups, and starting also ending all the way up to the major industrial houses. We do see a major push. And at this particular parks and all, innovation parks have been set up. For example, in Visakhapatnam, the AMTZ essentially focuses entirely on medical devices, and large number of people actually are incubating in Visakhapatnam to do that. And that's true all across the country.
Sure. I think we just have about 5 to 6 minutes left. Rashmi, you have some questions?
Sure. So while we've addressed a couple of questions directly during our session, I'll just take a couple of them till the time we have some time left. So this question is for Dr. Raman. Are there any predictive models for identifying populations at risk for post-infectious GBS?
Simple answer, quick answer is no.
Very nicely put, sir. So the other question is for Dr. Mukesh. How and what are the long-term neurological complications for GBS survivors, and what rehabilitation strategies show the most promise?
The major concern in the rehabilitation is about the level of physiotherapy they needed. So usually when they are weak and they are not need support, they usually try to stay on the bed maximum time of the day. Actually, such patient requires 6 to 8 hours of rigorous physiotherapy, similar like an athlete or similar like any sports person. So that point has to be put or pressed inside their mind. If you don't do it, you will not recover. The long-term rehabilitation concern is mainly development of contracture, joint contracture, which may require calcification around the joint, which may later require some surgical intervention. And what generally say in last my 15 years of practice, I have seen only 2 or 3 cases of this type of case. But so practically these are quite unusual. So, but just whenever such thing happens, just focus them, just mention them that if you don't move, if you don't use your limbs for at least 8 hours a day, whether passively or actively, you will not recover. Then this will come. Usually we see the average period of recovery 3 months to 2 years. In some cases of contracture development, even with the aggressive exercise, they can recover. So rehabilitation is orientation, training, particularly keeping them informed that okay, aggressive thing is important, and just go on. Then frequent means neurologist OPD visit and their discussions. So physiotherapy definitely rehabilitation, but I don't think anything lacking in our infrastructure. At tertiary care center, everything is available across all states, across all districts.
Okay. So the next question is for Dr. Shekhar. What role does molecular mimicry play in GBS pathogenesis, and are there ongoing efforts to develop targeted therapies?
So molecular mimicry presumably plays a big role because the antigens which are presented by these viruses or bacteria, if they look similar to certain components in human cells, then in those cases, what would happen is that the antibodies would also attack the human cells, just like they would attack the viruses and this. And typically to suppress that, what doctors like Dr. Mukesh Kumar and Dr. Ganga Ketkar and all would recommend is possibly give some kind of immunosuppressants so that the body's immune system doesn't really hyperreact to either the antigens or the body's own cells or something like that, and let the situation die down till the antibodies are actually produced against those kind of antigens. So molecular mimicry is known in many pathogens, and pathogens actually there is always ongoing race between the host and the pathogen, right? I mean, the pathogen is trying to establish an infection and the host is trying to clear that. And one of the strategies used by the pathogen is to mimic certain components of the human system itself. That's one of the things that it does. And that leads to autoimmune kind of reactions.
Just add to it, supplementing this. Whenever we talk about the autoimmune disease, particularly GBS, I'm not talking about the GBS, there is a monophagic course versus polyphagic course. Monophagic course, it means molecular mimicry is one-time phenomenon. It is not a long-standing phenomenon. In this type, you just need IVIG and plasmapheresis, no continuation of medication required. Okay, no immunosuppression required because it is a monophagic. It just happened, triggered, and gone. But in case of polyphagic course, where the molecular mimicry goes into a memory cells and then continuous processing the typical after the recurrence of some infection or something which we don't know. In that situation, you need immunosuppression. And here what you say about the marker or something like a focused treatment, guided treatment, then the role of biologics comes into picture. The biologics is monoclonal antibodies. Here, the one of the safest antibodies is rituximab, and which is widely available and across, but it is used only for the polyphagic course. If you see all of GB syndrome, so 1 in 10,000 GB syndrome, 1 in 1,000 GB syndrome, some cases go in, it is a starting of CIDP or a starting of polyphagic course, or a starting of something like a nodopathy. In that situation, it is you have to give immunosuppression, and which may be a 5 years phenomena. Your treatment is immunosuppression for 5 years. But we have to confirm polyphagic course. You have to confirm the neurological deterioration. So this is means that it is a super specialty job. It is not at the level of the public health. So if you say 99.5%, ensure you don't require immunosuppression or targeted therapy in GBC.
So last, we'll just quickly take this last question. This is open for all. How should vaccination campaigns address concerns about GPS as a side effect, as a rare side effect, while maintaining public trust? I think we've already got the nods.
Yeah, no, it's something which is very difficult to be done. Now, please remember one thing. If you want to tell every possible side effect of a given vaccine or a given drug, it is extremely challenging. It can create panic within the mind of that person or whoever is actually a caregiver. That would that happen? So generally, what is the route that you adopt? Only those side effects which are common are discussed, which are more likely to be frequent. Does that mean we don't respect patients' rights? We do. But at the same time, you need to balance everything. You can't be just going one way altogether. People have to understand there are certain things which can happen. You have to trust your doctor. Vaccines, if you look at the risk benefits ratio, will confer so much of benefit over a very small risk of 1 in 100,000 people. No, now why should you unnecessarily worry about something which is, it's like, going into the ground and waiting for a star to fall on your own self. No, can this happen? Yes, it can. But do I need to worry every day? No, no, you should not. No. I'm sorry.
Thank you. Thank you so much, Dr. Raman. And this brings us to the end of the session as we have run out of time. So, a very, very big thank you to all the experts for sharing their expertise to our audience for this engaging session today. It was indeed a very insightful discussion, and we have covered very crucial aspects like Guillain-Barré syndrome from its possible triggers to management and also important aspects about public health preparedness. So, Mr. Vikas, if you would like to also send in a message.
No, absolutely. This was the intent of really clearing up a lot of doubts that we are all having. And of course, from the side of the media, it's also important for us to convey the right signals rather than confusing ones, or, allay the fears rather than stoking them. So that's the whole idea. And thanks to all our esteemed panelists for giving their time. This is extremely beneficial for all of us. I hope you all are also, happy with the way the conversation flew. And thank you so much again, and appreciate your time. In fact, with all the medical terms that Dr. Mukesh Kumar spoke, I think we'll need a crash course of how to handle these medical issues. So, but still, sir, this was really very important. And thank you so much again. Really appreciate it.